Pankaj.
Yes, sir.
Good morning, dear delegates and respected faculty. We welcome all of you for the session on neonatal screening by Dr. Arun Kumar Singh. I request our President, Dr. Alok Bhandari, sir, to say a few words, and then I request Dr. Pankaj Garg to introduce the speaker and the chairperson and start the session.
Well, good morning, friends. Welcome to this elite platform of eNeo course organized by Delhi IAP. And as you know, we are into the academic forefront of the country and IAP. And it is a very welcome appearance today of Dr. Arun Kumar after a long time. Sir, आप जोधपुर चले गए हैं? Welcome, sir. Well, and my dear friend, Dr. Sanjeev Joshi from Yavatmal. He is a very active, energetic pediatrician who is of the not only of Vidarbha region, not only of Maharashtra, now at the national level. So, Dr. Joshi sir, welcome. है डॉक्टर जोशी का लिंक
जोशी का अभी भी मिस हो गया, अभी भी वो थे बट
हाँ
आई थिंक ही इज जस्ट, मैं उनको दोबारा एक मिनट मैं देखता हूँ कि उधर तो नहीं चले गए वो.
And Dr. Arun, you are still in car only अभी?
Yeah, I'm still in car. car.
कोई बात नहीं, हम तब तक टॉक करेंगे. हाँ, डॉक्टर जोशी has joined back. डॉक्टर आलोक.
हाँ, डॉक्टर जोशी सर, वेलकम.
Good morning, Alok bhai. Good morning, Pankaj sir.
Good morning.
Good morning.
अभी नजर आ रहे थे सर, अब आप नजर नहीं आ रहे. आप हमें देख पा रहे हैं?
थोड़ा मैं भी
थोड़ा ट्रैवलिंग में है, वो भी गाड़ी में है वो, इसलिए थोड़ी आवाज का कम प्रॉब्लम आ रहा है.
अच्छा, तो डॉक्टर जोशी, दिस इज एन इनिशिएटिव ऑफ ऑनलाइन टीचिंग कोर्सेज हैं जो दिल्ली आईएपी एवरी संडे मॉर्निंग जो है वी स्टार्ट एट 9 AM विद दिस टॉपिक ऑफ इंटरेस्ट फॉर द जनरल पीडियाट्रिशियंस. इसमें द neonatology course we have almost 700 registrations. Gradually more and more people will join, and today none other than Dr. Arun Kumar Singh is our guest speaker this morning. He will regale us. अभी पंकज और बताते हैं. And जोशी जी के बारे में तो I was just telling कि भाई he is a very dynamic, energetic force, not only from Vidarbha, not only from entire Maharashtra, but all the entire country. He is representing Central IAP in the executive board. And welcome, Joshi ji. And अभी आप बोलिए सर, डॉक्टर जोशी, how do you feel?
I think कुछ वॉइस का है, डॉक्टर जोशी का वॉइस आ रहा शायद. हाँ जी सर. So I request Dr. Joshi to introduce the topic for the day, which is newborns. I think we lost Dr. Joshi's connection. So first, let me tell you something about this course, because especially for Dr. Arun Singh and Dr. Joshi, we conceptualize this course for office-based pediatricians. I know neonatology is something which every pediatrician has to look after, even if he may not be doing core neonatology within the four walls of an ICU, but they are taking care of newborns every day in their OPD practice. So we have devised this course over 15 lectures, and this is the middle of the course. We are in the 8th lecture today. So we already covered topics like resuscitation, care of normal newborn, X-rays, investigations, imaging, hematology, jaundice, and today we'll be discussing about newborn screening. So before I hand over to Dr. Arun, a few words about Dr. Arun. Dr. Arun has been a great neonatologist, and he has been the pioneer in starting the facility-based newborn care. His Purulia model has been famous all over the world now, and from government and UNICEF, NNF, everybody conceptualized that idea from his work in Purulia, where facility-based newborn care was launched. And then after doing his job in West Bengal, he got shifted to ministry. And then he was instrumental in launching this newborn screening for birth defects, which RBSK has been very instrumental in starting this program in many parts of the country. And Dr. Arun Singh has been behind that model. which is there for newborn birth defects. And right now he's at All India Institute of Medical Sciences, Jodhpur. He's heading the neonatology department there. And the very peculiar thing about Dr. Arun is that he likes to talk, and he likes to talk. And whenever he talks, he combines philosophy with medical science, and then he makes it so interesting. So whenever I listen to him personally, I admire him a lot, because it looks like that we are listening to a story from a yoga teacher or from a saint who is mixing science with the spirituality, with the on past medicine, and with present concepts. So that is very interesting whenever he starts talking about it. So before I hand over to Dr. Arun, I will just, Dr. Sanjeev Joshi has joined back. Dr. Joshi, I like to request you to say a few words, especially about this initiative of IIP Delhi, and also about newborn screening, if you can say a few words. Dr. Joshi, you are...
Hello.
Yeah.
Hello.
We can listen. Yeah. Please go ahead.
Hello.
So you are audible.
You're audible, sir.
A very good morning to all. Ajay bhai, Alok bhai, and Pankaj sir. At the outset, I am extremely thankful for this wonderful opportunity, and I express my apology for this poor connectivity. At present, I am driving on the fastest highway of India, which is called as Samruddhi Highway, which connects Nagpur to Mumbai. I just landed from Mumbai after attending our state neonatology conference. Today's topic is neonatal screening, comprehensive neonatal screening. As we know that the Western world, we have in the Western world, neonatal screening is on a large scale since decades. We have also started neonatal screening, but it was only restricted to some special high-risk group like the NICU graduates who were admitted to NICU for some or other reason, or if at all we have already diagnosed an inheritable metabolic disease or some endocrine issues in the family. But now the need of the hour is to take neonatal screening at the mass level. And I think IIP has done a lot of herculean efforts for starting neonatal screening at the mass level. At present, for the state of Maharashtra, if at all I had to talk, we are doing screening of the high-risk babies at all the government institutions. And in addition to that, we also do thyroid screening. But the need of the hour is to have an expanded program of neonatal screening, because we know that we can identify so many genes, those which are responsible for inheritable metabolic disease, which will be ultimately detrimental if not diagnosed on the time. And we today are blessed with one of the genius in this field, Dr. Arun Singh, who has been already introduced by Pankaj bhai. I think I had an opportunity to listen to him in one of the webinar. Very towering personality altogether. So I just hand over it to Pankaj bhai.
Please unmute, Dr. Pankaj.
Yeah. Now
Thanks
I will
for this
not
wonderful
stand in
opportunity.
between the topic, which is the newborn screening, and Dr. Arun Singh, who is going to mesmerize all of you with his words of wisdom. Over to Dr. Arun Singh.
Thank you very much, Dr. Pankaj, and for this entire initiative. A very good morning to all of you. Today, we are going to talk about comprehensive newborn screening for birth defects, and I'm Dr. Arun Singh, already introduced, working at AIIMS Jodhpur. So the learning objective of today would be, we would start with the definition of birth defects. We will also learn how to examine the child for visible birth defect, functional birth defect, and in a short while, I'll explain what is visible and what is functional and what is neurological.
Sorry,
But
sorry,
Can you
Dr.
make it
Arun
full
Singh, your
screen, sir?
slide, yeah, make it full screen. Yeah.
Please make it full screen.
yeah. Okay, okay. 1 second. Just 1 second.
Can you stop sharing and start sharing again, sir?
Okay, okay, okay. I think that's what I would do. I would
Yes,
share
please
once
start sharing again.
Okay. Full screen. Slideshow. Is it coming full screen?
It is
No.
still loading, sir.
It is still loading. So full screen करने के लिए क्या करना है? Let me again stop share. Second share. ये है.
Sir, please stop the presentation also, PPT, and then start again.
Yeah, that's what I'm trying to do. Yes, quick stop share कर दें.
And reopen the PPT, sir. Please reopen the PPT.
Yeah, 1 second. एक बार काम करते हैं. Just a minute. हाँ. 1 second. अच्छा आप करो. ये Zoom पे जाओ, शेयर करना है. ये शेयर यहाँ पे करना है फुल स्क्रीन. अब बताओ कैसे करना है. Is it better now?
No, sir, it's same actually. Initially, it was coming good, like in the initial phase.
Yeah, I think. Answer. ये स्क्रीन करें. हाँ.
Please make it full screen.
Yeah, that's what I'm trying to do. It's not taking. ये इसी को बड़ा कर दें क्या? प्रॉब्लम तो हो रहा है. ये करना है स्क्रीन टू या ये नया खोलना है? स्क्रीन. I think the.
Sir, it is sharing your screen rather than sharing the screen. Please share the PPT. उसमें ना, if you go to the options.
Okay. I got it. Okay, I got it. It is sharing the screen rather than the PPT.
It was very clear, sir, in the beginning.
Please
Yeah.
stop sharing and then again choose the option of share. Stop sharing, sir.
I think.
Arun, should I start from my
This is
side?
an
Just
issue.
stop sharing. Let me do it from my side.
That you can also do.
But
I
Arun,
think
just
that would
stop
be
sharing.
good.
I'll do it from my
Okay.
side. Stop it for the.
Okay. So
Let me
so
see.
what I do is
Sir, you stop
just-
sharing, sir. Please stop sharing.
Okay. Leaving. क्या हो गया?
Mr. Anil, Mr. Sushil,
मैं कर रहा हूँ 1 मिनट कर रहा हूँ 1 मिनट बस जस्ट गिव मी
नहीं नहीं, आप सर का शेयर बंद कर सकते हो?
Yes, sure, sir.
Yeah, what I do is I exit out and come in again. I think
Yes,
there's-
sir. Okay, sir. Right.
Okay.
डॉक्टर आपकी स्क्रीन आ रही है वापस करेंगे तो आएगी
आ रहे हैं 1 सेकंड में इसको बंद कर
सर आप दोबारा लॉगिन कर लीजिए सर, एक बार एग्जिट कर।
अब खत्म हो गया ना?
अभी भी है
अभी भी है।
हाँ
सर मैं अब बंद कर दिया सर, बंद कर दिया। डॉक्टर पंकज,
let me just do it from my side.
हाँ
अब आ गया। It's all right. It's visible to you, Dr. Arun?
Yes, sir. This is good.
Yeah.
So
Please
let
start.
me just whenever you say, I'll change the slide.
Okay.
Okay. Sorry for the glitch. I think we'll go back to the topic, comprehensive newborn screening for birth defects. Next, please. And today's objective would be to understand the definition of birth defects, how to learn to examine the child for visible birth defect, functional birth defect, and in a very short while, I'll explain you how we have differentiated visible, structural, functional, and we'll also talk about how to document the birth defect to know the initial management and know where to refer and when to counsel. Next, please. So when you see a child, not all children are born healthy. And we use the word congenital, which means starting at birth, though birth defects may not be visible at birth. But for a point, just see, you have a cleft lip, you have a Down syndrome, you have a neural tube defect, you have congenital deafness, you have thalassemia, you have sickle cell anemia, you have congenital hypothyroidism, and you have congenital cerebral palsy. Can we click the slide once more? So these defects which you see on your screen, some are visible with a naked eye, some in which you have to use an instrument, and in some you have to be invasive and take a drop of blood. So we will divide it according to how we are going to identify the birth defect. Things like cleft lip, neural tube defect, they can be seen visibly. So we call them visible birth defects. Things in which we require an instrument to test the functionality. Ear is an organ and hearing is a functionality. So when you test hearing, that's a functionality. So if there's any defect, that's a functional birth defect. Eyes are there, but vision is a functionality. So when you test the vision, you test the functionality. So congenital deafness, any problem with vision, or congenital heart disease, the functionality is again through. So all this requires an instrument, and this we call functional birth defects. The third thing is what is not visible. What is not visible on the use function, but you have to do a CT, MRI, or a fundoscopy. In such cases where you are using an instrument to define the structure which is not visible from outside, this will be known as structural birth defects. Then you now prick the baby. Up till now, we were non-invasive. Now, when you take a drop of blood and you screen for hemoglobinopathies, which consist thalassemia and sickle cell anemia, or congenital hypothyroidism, congenital adrenal hyperplasia, which are a part of inborn error of metabolism, then this becomes a metabolic screening, where you are taking a blood to screen a metabolite. And then lastly, once this baby is in your NICU, sick newborn care unit, and you are about to discharge, so you clinically examine the child. And if you find a neurological problem clinically, then we will call it a neurological birth defect. So this is for the ease of screening. Next slide, please. Next, please. Yeah. Next, please. So let's define what is birth defect. This is, yeah. So as you can see now on your screen, visible birth defect is what is visible right at the go. So it can be neural tube, cleft lip, cleft palate, limb deformities, clubfoot. Functional, as we have talked about, congenital deafness, congenital cataract, congenital glaucoma, or congenital heart disease. For this, you require an instrument, but it is still non-invasive. In metabolic, you have to be invasive. So you are diagnosing either the commonest one in our country is hemoglobinopathies, followed by G6PD, and then some of the things which is very vital for screening, because newborns appear all normal when you see them. So you must screen for congenital hypothyroidism and congenital adrenal hyperplasia before it is too late. Chromosomal is a structural screening. Some of the chromosomal defects you can identify, but to know the structure, you have to do a karyogram or a genetic testing, or you do some neuroimaging. So this is how you can pick up a structural defects. And lastly, neurological, I want to tell the residents to please also include it, that before you discharge a baby, please examine clinically a child for any neurological birth defect, by which you may pick up a congenital CP or a preterm birth associated with a birth defect. So these are our pillars. So when you say newborn screening or screening for birth defects, you have examined each one of the pillars, which is visible, which is functional, which is basically non-invasive, metabolic, which is invasive, chromosomal structure, where you are doing ultrasound, CT scan, imaging, and neurological, which is clinical. Next, please. Next slide. So what is the magnitude? Now, if we include all the birth defects, then out of every 100 baby, you have 6 to 7. But this includes both major and minor. So major birth defects, which you should not miss, is 2 to 3. So India, with a birth cohort of, let's say, 2.6 crore, we have 17 lakh babies born every year. And this has got a relation with the deaths. So it contributes to 9.6% of all the newborn deaths. And the major, when we did under RBSK a massive screening, state after state, we found very similar to the Western data. The commonest one was among major defects, congenital heart disease, which was 1% of the population. And majority of them required to be treated surgically, and that too within a year, which is known as the critical congenital heart disease, sometimes within 1 week of the birth. Things like transposition of great arteries, where you cannot wait. Then after this, we had neural tube defects, you had cleft lip palates, and then as you move on, hemoglobinopathies, Down syndrome, and G6PD. 70% of the birth defects are preventable. Next, please. So as I said, the incidence is only 2 to 3%. And when you are examining, please do not forget to examine every part of the baby. I often see the residents, they examine the child, but they don't examine the eyes. So eyes with a simple torchlight, and then we'll also show you how to do the red reflex. This is very, very important. The problems would be 2 to 3 per 10,000 babies. They require treatment. In preterms, we also have a problem of both myopia of prematurity and also the problems of the premature retinal vessels, which will come in a while. Then congenital hearing loss. Now, this is very interesting. Congenital hearing loss, if you do in a large-scale population, which you usually follow by an instrument called autoacoustic emission, this would be about 1.68 in 1,000 normal babies. But the moment you start screening your NICU or SNCU graduates, it increases 10-folds. So it is now 10.6 per 1,000. And these babies, which are NICU graduates, we call them high-risk babies. So overall incidence is 3.54 per 1,000 babies. Neurotuber defect is something which is not across India. In the northern population, it is far more. And it, if we go through the ICMR 1983 data, it is 0.5 to 11 per 1,000. And the Lancet 2005 puts it somewhere between 6 to 8 per 1,000 live births. Cleft lip and palate, it is again about 1 per 10,000 births. This is data from AIMS. Heart, I have already said 1%. Congenital dislocation of the hip, which was the earlier name, and we now call it more of the dysplastic. So it is 1 to 2 per 1,000 babies have hip problems and require treatment, especially if you find a female child, if you find a breech delivery. Always have a very high focus for screening the hips, hip joint. You should not miss it, because there's a much higher chances if there's a familial history, if the child is a female or has a breech delivery. Testicular, in case of male babies, it is 1 in 100 baby boys which have some problems with the testes and requiring treatment. Next, please. So the causes is genetic defects is 10 to 15%. It could be some infection during pregnancy, which you can avoid. So we always say, please be vaccinated before you become pregnant. At least the government of India is also stressing on it. You can prevent congenital rubella syndrome, prevent other infections which are there. And if there is some person with viral infections during pregnancy, especially the first trimester, we need to avoid it. One of the common, very important things that before a mother becomes pregnant, I think it's a nice thing to prevent birth defects, that she gets examined for her weight, for diabetes, for hypertension, for obesity, and for thyroid. These simple examinations before you conceive, this is prior to you conceive, if you can screen it and treat it, the chances of birth defects will become less. Exposure to toxic chemicals and medications. You all remember the famous Minamata Bay disease, where a factory was releasing mercuric chloride in the water, and the fishes were taking this, consuming it, and especially the fatty fishes. And then this was being consumed by the pregnant mother, and it was getting transferred to the baby. So toxic chemicals and medications are very, very important, and there are historical evidences that they can cause huge birth defects. Teratogens, sometimes we tend to conceive without knowing we are pregnant, and the first time when the mother comes, remember, even when you test for pregnancy, it's already 4 weeks past, and if she's already on some medicine which can be teratogenic, then it becomes very difficult. So again, my advice is that post-marriage there should be a counseling, and there should be a checkup. Multifactorial, some of the factors. Next, please. Next, please. So this is the examination which we are doing: visible birth defects, pulse oximetry, hearing screening, mass screening by OAE, but in case of nursery graduate, it is better to use screening beta and metabolic screening, and then after all, you can do structural screening and neurological screening. So visible birth defects should be screened in 24 hours. What is the point we are trying to make? In case there is some visible birth defect which needs to be treated within 24 to 72 hours, please identify that, and that's the highest priority, because otherwise the child will die. Then, of course, you should do pulse oximetry within 24 to 48 hours, OAE screening also near 48 hours, and metabolic screening after 48 hours. Once the child has received feeding, it is better to screen after that. Next, please. Next, please. So we have talked about that, how the visible birth defect, which is the most, you don't require any money. IIP can take the initiative that every baby born in this country can have at least a visible birth defect screened either by a doctor or by a nurse. This is what we should teach. And this can be done from head to toe examination. Just after the baby is born, take some time. Once the baby stabilizes, please screen for it. And remember two things: we need to follow head to toe, but you can change accordingly, but at least you should know that you have covered everything. Next, please. Next. Yeah. So this is how you should. So when you are examining, please remember that you have hand washed, you have checked for vital signs, and if the baby is not stable, please allow the baby to become stable. And how do you know that? Please measure the heart rate. We expect that when the child is awake, his heart rate would be 100 to 180, and in sleeping would be 80 to 160. But if there is a tachycardia, that is more than 160 during sleep, or there is tachypnea more than 60, then first stabilize the baby. Don't start examining the baby. So two messages: first stabilize it and make sure you have done the hand washing. You have made the baby comfortable the way you can see it on your screen. Record the date and time of examination. Record the general assessment and measurements. And these are the headings under which you should examine: the skull, the face, the mouth, the palate, the nose, the ear, eyes, chest, moving down, abdomen, arms, hands, legs, feet, genitalia, anus, spine, and skin. This should be, you can be flexible. You can examine one thing earlier. So if the infant is quiet and relaxed when first approached, then you can first examine his respiratory rate and etc. before you tend to touch him. Next, please. Next, please. So when a nurse is training, or even a young resident is training, and you cannot identify exact name of the problem, make sure that you have a drawing and you just make a circle on it. And so you can take an image of it. So you should know how to capture it. All of you have smartphones, how to capture the image. And then you can have people refer to it and you can talk to them. So this is a simple way of putting it, that what are the usual things which we find in head and spine, face, eyes. And when you say eyes, start from even before the eyelid, the area around the eye. So if there's a port wine stain, see it. Eyelid, see for any hemangioma, see for any ptosis, see for any coloboma. Coloboma is a Latin word. It means a gap. So if there's a gap in the eyelid, we call it coloboma of the eyelid. If there's a gap in the iris, we call it coloboma of the iris. If there's a gap in the retina, we call it coloboma of the retina. So then you see the shape and size of the eyeball. Is the eye big, or is the eye not at all formed? So A in Latin means no, and ophthalmos is eye. So the eye is not formed, it is anophthalmos. Or if it is small, then we call it microphthalmos. Sometimes you also find a large eye, and you should look for intraocular pressure. And I must say that I have seen plenty of babies in some pockets of our country where they are born with biophthalmos, which means that they have very high intraocular pressures. Then you should move inside the eye. Now, eye is a game of three circles. So the first outermost circle is your cornea. So see for any corneal clouding. Then look inside. You can use your simple torch and see the second circle, which is the iris. So is the iris of one color? Is there heterochromia of iris? Is there a gap in iris? We then, as I said, coloboma is always gap. Then you can look for any congenital cataract where you'll have like a pearl, white pearl. And the differentiation between corneal clouding and congenital cataract and congenital glaucoma is congenital corneal clouding will be may not be round, but congenital cataract will be beautiful, round, white, pearl-like. And congenital glaucoma, you cannot differentiate between the corneal circle and the iris circle. Everything may appear white or blue. And there will be tearing of the eyes. So if there's a tearing of the eyes and you think that it looks like a corneal clouding, most likely you're dealing with congenital glaucoma. Then you look at the ear shape. We all rush to hearing, but the structure of the ear shape is also equally important. Is the ear rotated? Is the ear low set ears? Is there structurally a problem in case of anosia, microtia? And as I said, low set, then you open the mouth, the cleft lip and the cleft palate. Sometimes the mucosal cleft palate is missed. So you have to use your finger and from posterior to anterior see. And if you find that there's sometimes you can look at the uvula, and if there's a bifid uvula, you would think of that, are you missing a submucosal cleft palate? Then start coming to the chest, see for the respiratory distress, etc. Then come to the abdomen. Is it scaphoid? Is it distended? Or is there a gap in the skin of the abdomen? Is there any herniation? So all this will come, and please do not forget both in male and female child to examine the anus. And two questions is you have to see, is the anal opening situated at the right place or is it functioning? So is it imperforate or it is ectopate anus? And then in the urinary tract, see for the bladder, if it is open. And whenever it is a male child, please remember to see before you discharge, the flow of the urine. So this sometimes can allow you to pick up a posterior urethral wall, and on inspection also see the lower abdomen. Is it prune belly, which the pruning word, especially if you have seen in gardens, etc., you can make it out. The belly is looking prune-like, and you can then think of a prune belly syndrome. But most important is see where from the urine is coming. Is it at the tip, especially in a male child, or is it above the penis, or is it below the penis? If it is above, then EP means above, so it is epispadias. If it is below, it is hypospadias. Then you look at the genitalia. Can you make out a male or a female child, or is it ambiguous? See, as I've said, a urethral, and then see for the limb. In the limb, what do you see? Is there any reduction defect? There's something is missing. So the forearm, arm, or the fingers, is there missing? Is there any extra curvature? Okay. Or is there any extra finger, or two fingers have fused? So you should look for polydactyly, you should look for syndactyly, and also oligodactyly. Next, please. Next. I think you'll have to move the slides faster, otherwise. Yeah. So once you have found that the vitals are stable, look at the posture of the baby, and you should know the gestational age. Now, you can say the predominant posture. So before you disturb the baby, when you are examining, look for the predominant posture. It is normal or abnormal. Now, there is one posture which is always abnormal. What is that posture? If you get a child with hands flexed and legs extended, this is always pathological. Because as we know, in maturity, it starts within the womb up to 40 weeks from lower to upper. So first your legs will get flexed, then your trunks will get flexed, and then your hands will get flexed. So if you find the legs are extended but the hands are flexed, this is abnormal. So you should identify any abnormal posture. It is nice to record the state of alertness, whether the child is active, drowsy, or sleepy. The activity, the spontaneous body movements, the eye movements, the facial movements, the breathing pattern, and level of response to external stimuli. And on your screen, you can see some of the babies which have abnormal postures. Next, please. Next slide. So you can see that sometimes you must know the gestational age before you say about the posture. And I have already talked, see the color, see the posture, tone, activity, maturity, and quality of cry. Sometimes we miss this. We say that this is not required, but it's a nice thing that when you're examining for birth defects, you complete this exercise. Next slide, please. Next, please. Next, yeah. So these are some of the abnormal postures. I think this presentation will be given to you so you can see in great details. But what you see, the black and white presentation, the fourth child from the left, this is a term child. So you see the flexor tone is a normal tone and this flexion increases. But if you see the fifth child, his hands are flexed, but legs are extended. This is always abnormal. Next, please. Next. And you should start with having proper instrument to measure. So starting with the head circumference measure. Now, in Latin, micro means small and cephaly means head. So we can have congenital microcephaly, or if the head is large, then it is congenital macrocephaly, which is more than 2 standard deviation. And when there is a macrocephaly, you should know whether it is because of the skull bone thickness, is it because of a subdural fluid, or is it because of hydrocephalus, or is it because the brain, the encephalon itself is big, which is megalencephaly. When you are examining hydrocephalus, please do not forget to do the transillumination test. And remember, sometimes you have to differentiate congenital hydrocephalus into obstructive and non-obstructive, depending upon the fourth ventricle, which you can see in your USG. But clinically, do a transillumination test. And some of the common differentials which you must keep in a newborn who has just been born is hydrancephaly, where there is hardly any cortex, or a large porencephalic cyst. So remember to do the transillumination in a bright light when you are examining. And also remember that some of the anatomical megalencephaly can be seen in cases of organic aciduria, in case of lysosomal storage disease, and Canavan's disease and Alexander disease, which are found in some of the populations of this country. The next is to take the weight, the length, the head. So when you're examining the head, see the shape and symmetry, see the scalp swelling and deformity. Don't forget to examine the anterior and posterior frontally, and you can get craniosynostosis if you miss, and measurement of the head circumference we already said. And is there any neural tube defect? So when you're examining head, sometimes you will find that there's excessive molding, which is normal, or there could be caput, which is limited by the suture lines. Now these are normal, but you also should pick up cephalematoma, which residents do pick up. Sometimes they miss something which is very emergency, is subgaleal hemorrhage, where the swelling crosses the midline and the suture lines, and you find the baby looks lethargic, looks pale, and there's some swelling. So don't miss it out, because this could be an acute emergency and a subgaleal hemorrhage. But what I'm saying is that please examine the anterior and posterior and do not miss craniosynostosis. Next, please. Next. Yeah, and sometimes when the baby is born, you'll find that the baby's hand is in a peculiar position, what we call the brachial plexus injury of the upper trunk, which is also known as the Erb's palsy. It's upper C5 and C6 trunk, or it could be the lower, and this is lower C8 and T1. So And sometimes when you're examining, also examine the clavicle for any fracture, any crepitus. Sometimes the clavicle may be missing or there may be a fracture in the clavicle. Next, please. I would tell you, see on your screen, there is a baby. This had come to us. He was born at AIIMS Jodhpur. And the residents noted that there was asymmetry of the face. And they thought this is a normal variation. But whenever you get such an asymmetry of the face, in fact, the mother was a nurse there, I immediately thought of doing a CT scan, and we found that this was a case of craniosynostosis. So on one side, the coronal suture had fused, and you can see the picture of the CT scan. So whenever you get a deformed face, one of the things you could also think could be the skull shape, which is leading to the so you can pick up a craniosynostosis by looking also at the face. Okay, next please. So we have already talked. A means absent, encephalon, so absent of the cranial vault, where you should not refer this case because nothing much can be done, but we can prevent it from the next by making sure that they are given adequate folic acid, their blood sugars are controlled during before they conceive, and they are some people would also try to prefer B12, but folic acid is something which has brought down these neural tube defects. And sometimes you find a swelling behind the brain. So encephalon means brain plus seal is herniation. So there's a herniation of the brain, and you should see where it is herniating. It could be frontal area. So it could be frontal meningoencephalocele, or it could be occipital meningoencephalocele. And whenever you are please also look for the associations of Arnold-Chiari malformation or Dandy-Walker malformations. Next, please. So when you look at the face and you see rhinoencephaly, A means absent and rhin means a nose, and encephaly is brain. So there is absence of the nose. There could be congenital absence of the olfactory bulb tract or the nerves. It's a developmental operative, which is a part of the olfactory. So sometimes you can see cyclopia. So as you can see on your screen, there's a single eye. But sometimes you may miss it, but always look on a CT scan, and sometimes you can also pick up on the ultrasound, holoprosencephaly. So what does this word mean? Holo means whole or undivided. Pros is the fore or the forebrain, and encephaly is the brain. So holoprosencephaly is an incomplete or absent division of the forebrain or proencephalon into distinct lateral cerebral hemispheres. Okay, so these are the lobar, semilobar, and alobar. Next, please. So please look at the facial asymmetry, and sometimes you have a baby with protruding tongue. Now, I would say this is not a newborn, slightly later. So if you get a picture of cretinism, then we are doing a big mistake. Ideally speaking, congenital hypothyroidism at newborn, they look alike, almost normal. So by looking at a child, you cannot say this is congenital hypothyroidism or not. And if you treat early, you save the IQ. But once it comes with the florid features, what we earlier used to talk about cretinism, then it is too late. You can treat it, the child will improve, but will never have the same IQ. So the bottom line is, it is nice to screen for congenital hypothyroidism at birth, because the IQs may be lost if you treat it later. And you also have a baby on your screen which has both eyes are closed, and there's an asymmetry. When it's crying, there's an asymmetry. So on one side, there's a pull. Okay, next slide, please. So this is facial asymmetry on crying, or also known as asymmetric crying faces. So this could be because of congenital aplasia or hypoplasia of depressor angular oris muscles. So whenever the baby cries, the mouth is pulled downwards on one side while not moving on the other side. This should be differentiated from a traumatic seventh nerve palsy, which is that the eyelid is not affected in case of Asymmetrical crying faces because of depressor angularisoris muscle. The eyelid is open on the affected side, no movement from forehead to chin, and loss of nasolabial folds. So this you should be using it to differentiate. Next, please. Next. So as we move down, so you have already talked about appearance, head and spine, face, eyes, ears, mouth and lips, chest, respiration, and the ones which are marked with red, you should refer them immediately. So if you have a baby with dysmorphic features, you can have time to examine. But if you have a child whose abdomen is distended, has not passed stool, or has having bilious vomiting, or is having central cyanosis, or having an enlarged or bulging frontally, then you know the ones which are red. So we have divided the whole newborn examination by taking out which entities needs to be referred within 72 hours, which needs to be referred within 1 week, and which you can wait till 1 month and you can stabilize it before you send. So there is no panic in terms of referral. You just say referral to a bigger center. The parents think this is an emergency, and there the doctor says, well, you can come to me after 1 month. Now this creates a gap in our understanding. So this is how you should go: chest, respiration, heart, abdomen, anus, genitalia, urinary tract. So I will not go, these slides will be there with you, but just to know the ones which are red need to be cared immediately. The residents must discuss it immediately because time will be running out. Next, please. Next. Yeah, so just starting the year, we have talked about it, but a good idea is that you should identify every structure: the helix, the tragus, the external auditory canal, the lobule, the antihelical fold, because if you find there is a gap, then you should know where is the problem. Next, please. So this is for the beginners, but sometimes it is. So the low set ear definition has changed, but for the time being, we are still using that the line drawn from the outer canthal should cut 1/3 and 2/3. And the current is that the low set ears is that you have to draw the line from both the outer canthals and see it. Whatever it is, whenever you are diagnosing low set ears, please also see whether they are dealing with posteriorly rotated ears or not. Next, please. So I have already talked about, and you can see the various microtia. So people do hearing screening, but they should also report the structural ear defects, which can be visually picked up. So this is all a part of visible birth defects. Next, please. So you can see the ear tag, you can see the preauricular pit, the hypoplastic low set ear, and then comes the hearing. Now, only one statement I will make, that OAE screening is nice for every baby in the community. But when you want to screen graduates from your NICU or SNCU, it would be nice to have a screening bearer, and you can see. Later on, if the child comes for your follow-up, you can use a very low-cost ERFI AP2 audiometry, where you have frequency ranges and you can see the response of the baby. But whenever you are screening, we have developed a format for hearing. So just don't say hearing screen passed or failed. See also for the risk factors. Is the hyperbil? Is the birth weight less than 1500 grams? Have you used any ototoxic drug in terms of aminoglycosides, in terms of diuretics, especially Lasix? Has the child been on mechanical ventilation for too long? Is there a craniofacial abnormality? So you should complete the history. You should visually inspect the ear, any risk factors, and then do the hearing screening. My question is, sometimes the hearing screening is passed, but there is a risk factor. Tell the parents that there is a risk factor, so you need to be screened once more. So the newborn screening is not the final screening. So sometimes we tend to forget that, okay, we have screened and the child has passed and so on. So always look for the history and also for the ear defects, visible ear defects. Next, please. So in the eyes, we have said, start from the eyelid. So you can see a hemangioma, you can see a partially closed ptosis. As I said, coloboma of the eyelids, there's a gap in the eyelid. Then start seeing the eyeball abnormalities. Is the eye not at all formed? So I have worked in Purulia, where there were villages after villages. There was anophthalmos. There was no eye getting formed. This is because of certain genetic defects, or there could be microophthalmos. Then you should go inside the eye. And as you can see, the congenital cataract, which looks in the second circle, not in the outer circle, you can see a white-like structure, like a pearl. In Hindi, we call it motiabind. It resembles a moti. And then you can see congenital glaucoma, where there is corneal clouding. You can't differentiate the two circles, and there is tearing of the eye. So this. Okay, next, please. So you examine the eyes, ears, and then again the same format is there. So you talk about the risk factors. You know how to examine, start from eyelid, start from eyeballs, then come to any facial marks, look for conjunctiva, then look for the within the eye. So all the structures, cornea, the lens, and also for the blue sclera, sometimes you may pick up a dermoid, which is a very common feature in golden head syndrome. And this becomes very important if you find that it is encroaching the pupil. In that case, it requires an earlier treatment. Next, please. So we have already talked about mouth and lips. Next, please. The chin. So always remember to see the micrognathia or a Peary-Robin sequence. So the other day, my residents were saying that they searched for the palate, which was missed. This case was referred from outside, and there was a posterior cleft palate, which was missed. So I said, why did you suspect? Because they found that this was a part of a Peary-Robin sequence. So if you see a receding chin with backward displacement of the tongue or posterior cleft palate, then you need to see it for chin. Next, please. So web neck, in certain cases of Turner syndrome, you have to find it, or a cystic hygroma, so a huge swelling in the neck. Okay, you should need. So you should divide the neck swelling, whether it's a midline or lateral swelling. Is the swelling translucent? Is there a bruit in it? That's how we would examine. Okay, next, please. So palpate the clavicle, and it's a nice idea while you're examining the Moro's reflex. And if you see the Moro reflex is asymmetrical, is that got something to do with your clavicle? Next, please. Next. So this is just to see how we are examining. We can skip this video just to show you that how you are examining the Moro's reflex. Then you should come quickly to the chest, see the shape, symmetry, the nipples, the anterior chest wall, including the clavicles and the rib, and auscultate for the position of heart sounds and the breath sounds. Next, please. So what do you see? So you look for any nasal flaring. Is there any eye contact? Is there accessory muscles being used? Is the skin pale and cyanotic? Is there increased respiratory rate? What is the shape of the chest? Is it funnel-shaped chest? Is there a tachypnea? Is it associated with tachycardia? Is it cyanosis? And when you're looking for cyanosis, please remember lips is not central cyanosis. So for differentiating central cyanosis, you have to turn the lip inside and see inside gums. Because only mere lip could be also a peripheral cyanosis. So chest wall recessions, supracostal, intercostal, and subcostal cyanosis. So in short, you are going to see for tachypnea, you're going to see for intercostal retractions, you're going to see for nasal flaring. This is a classical example of June asphyxiating thoracic dystrophy. Yes, please, next, yeah. So you can see a narrow chest and horizontal ribs. This is Poland syndrome, and what do you see? You see, next, please, I think, yeah, just hold it. So we are seeing the pectoralis muscle is missing on one side, and see this newborn, you can make out the asymmetry. So unilateral hypoplasia, aplasia of the pectoral muscles, the memory hypoplasia can be associated with ipsilateral limb anomalies. Next, please. So the nipple abnormalities, next, please. Yeah, so sometimes you may identify congenital diaphragmatic hernia by just auscultating. So instead of the apex being on the left side, you are getting a better heart sound. Remember, in newborn, heart sound is conducted all over, but try to identify which is the best place you are hearing. So if it is on the other side, which is one of the commonest varieties of congenital diaphragmatic hernia, then you should think about it. And if the child is having a respiratory distress, you can. So just by mere auscultation, CDH can be identified. Next, please. So all this you know, but it's just going to repeat. And if there's excessive frothing, you need to diagnose tracheocecal fistula, and you need to send a tube inside, a rubber tube. Sometimes if you send a Riles tube, which I don't like, it gets encircled, and this is how you come to know. So you can see on the X-ray. Next, please. So now come to the deformity of the spine. So your spine is sometimes missed. So please see the curvature. You could pick up congenital scoliosis. Sometimes the neck, congenital torticollis, where the child has a persistent tilted neck. So look for the curvature of spine and look for whether the spine is intact or not. Next, please. These are the abnormal curvatures, and you can see the babies which are abnormal in the shape, because so you should know the normal physiology about your curvatures: cervical, thoracic, lumbar, and sacral. These are the 4 natural curves in the vertebral column. So you should pick up scoliosis, kyphosis, and lordosis. Next, please. And if there's a defect, if there's any tuft of hair, the dimple along the intact spine, and this should be seen. Sometimes you get a hemivertebra or a wedge vertebra. This you should not miss it. At times it cannot be clinically seen, but if you see a sudden deformity like this tuft of hair, dimple, you should think about it. Next, please. And this is a chart which I have prepared. This I prepared it for the nurses, but there's a nice idea to have it in your labor room, and IIP can make sure that it is there. So it gives you that you don't forget how to examine the head and spine, what are the commonest problems, how do you examine eyes, ears, mouth, lips, abdomen, anus, genitalia, urinary tract, limbs, upper and lower, and chromosomal. So this is all a chart for visible birth defects, and there's a book for it, which is Atlas. You can go through it. So you can remember, you can pick up all these without any single investigation, without any wasting any money extra. Yes, next, please. The ones with the red marks are the ones which you should do. So I will not go into this, but just we have reiterated that when you see an abdomen and anus, scaphoid distended. So scaphoid is like a, so inside there's a, what you could say, there is a depression, and distended is the opposite of it, or there's a defect in the abdominal wall, which could be gastrochiasis, or and then you should look for the abdominal opening, whether it's absent or there is imperforate or it is abnormally located. You should always see the umbilical vessels. So remember, there are 2 arteries and 1 vein, 2 umbilical arteries and 1 vein. You should look for hernias and hydrocele, both umbilical and inguinal. Next, please. So this is the gastroschisis and the omphalocele, and you are always asked how to differentiate between the two. So gastroschisis has no covering with the membrane, as you can see, and most important is that the defect is to the right of the umbilicus. So you can see the umbilical attachment. In case of omphalocele, it is covered with a membrane, and the cord attached is, so the defect is within the umbilicus, so you can't differentiate it separately. And this is seeing how you should differentiate an imperforate anus or a anorectal atresia. Next, please. So there is a book which you there's a book written, which is from RBSK, Visible Birth Defects. You can go through it, but your textbooks will also describe it. So when you are seeing genitalia, especially a male, see the penile size, which is a small penis, which will be less than 2 to 3 centimeter. Check for the urethral opening, whether it is located at the tip of the penis or located above or below, which I have already said. Palpate the testes. Sometimes they are retractile testes, so be careful before you say antecedent testes. And if there's any swelling in the scrotum, please remember to do a transillumination test, and it could be also congenital hydrocele or sometimes congenital inguinal hernia also. And in case of female, I would ask you that please practice this very nicely to identify the urethral opening, the vaginal opening, and the anal opening. Sometimes this is missed because it is covered with a, and the mother is may also miss it. So before leaving a child, you should examine all the openings properly. This is the hypospadias, the epispadias, and the bladder extratrophy is an extreme example of epispadias, which means above the ambiguous genitalia and the vaginal agenesis. Next, please. So once you have examined the genitalia, and then you should also think about the urinary tract. So the bladder extrophy, the posterior wall. So as I've already said that your bale stream should be seen. You can see the pruning of the wrinkling. It's like an old man appearing wrinkled. Also, this is pruning and undescended testes, and sometimes you get a very flat faces with a history of oligohydramnios, and this could be a Potter's syndrome, which is usually associated with bilateral renal agenesis. Next, please. So remember, the amniotic fluid is formed. Next, please. Amniotic fluid is formed by the baby swelling it properly and then excreting it through the urine. So if there's any obstruction, it leads to oligohydramnios. So next comes to limbs. So you should see whether there's a congenital complete absence of upper limb, or is it there is absence of arm or forearm, or it is absence of both forearm and arm. And you can see phocomelia, a very common thing. This happened when some of the mothers were taking drugs for vomiting, and this led to phocomelia, but we don't see it so common nowadays. But absence of hands and fingers, or syndactyly, polydactyly, or lobster claw hand, which you can also find in the foot. Next, please. So these are known as reduction defects of the upper limb. Next, please. So now we go to the lower limb, and the same thing, whether there's a congenital absence of foot, toe, or there's a congenital shortening of the lower limb, there's syndactyly, polydactyly, club foot, and we should try to see for club foot and differentiate it from metatarsal forces. So this reduction defect. So the whole exercise now has been done from head to toe. Next, please. So the sequence is head to toe and then back to front. Next, please. But you can change the sequence based on it. This is just a beautiful slide which just tells you how do you go from general observation to head, spine, face, eyes, mouth, chest. So we have gone through this whole, we have talked about much about it. Next, please. Now comes the functional. Now, as I said, the second part is now you have seen it visible. Now, visible does not require any money. It can be done in the remotest PSC of this country. Now you want to do functionally. So for functional, what are the instruments which you require? So you require a torch, you require an ophthalmoscope. We at AIIMS Jodhpur have designed out something better. We'll talk about it. So this will examine your eyes, inside the eyes. So this is non-invasive and you can see. So you can see if the eye looks red, then it is normal. If the eye doesn't look red, that means. So what is the red which you are seeing? You are actually seeing the retina. How can you see the retina? If your cornea is transparent, your aqueous humor is transparent, your lens is transparent, your vitreous is transparent, then you can see the posterior most part, which is the curtain, from looking from outside. So if you can see the retina color, which is red, that means all these are transparent, which is one of the things. If not, then there could be a corneal problem, there could be an aqueous humor problem, there could be a lens problem, there could be a vitreous problem, or there could be a retinal problem itself. So when the eye is not red, even it could be a retinoblastoma. So this is how we differentiate. Next comes to hearing. We have talked about OA and screening bearer. I think screening bearer is nice for children with SNCU and NICUs, and you can pick up a lot of things, including cataract and glaucoma. Congenital heart disease, please don't only rush to pulse oximetry. First see it clinically, and we'll come in a while. And then use your stethoscope as well as do the pulse oximetry. Next, please. So what are you doing in the functional? Next, please. You are examining the eyes, you have examined the ears, you have examined the heart. Next, please. So this is the red reflex, which you are seeing it. Remember, to see the red reflex, you have to put off the light, you have to create a darkness dimly, because then only the pupil will dilate. and then you need to see through an ophthalmoscope. If this has to be done by other people, next please. Next please. Yeah, so if you see beautifully, it is red, so you see it from a distance. Remember, all old cameras could see the red reflex, but later on, people wanted the red to be removed. So that is why the current cameras, the flashlight gets open first, and then there is a pupillary constriction, so you can't see the retina. This is how the red has been removed. But if you use old cameras, you can get the red reflex. Next, please. Next, please. Now, when you are examining the heart, I would say see for two things, feel two things, hear two things, and do one thing. Game of 5. What do you see? See for cyanosis. See for respiratory rate. What do you feel? Feel the pulse, especially the femoral pulse, and do the perfusion test, CRT. What do you hear? Remember to hear the second heart sound and if there's any murmur. And what do? You do a pulse oximetry. So what do? You use one hand and one leg to see the difference in the pulse oximetry. So usually if it is 95% or higher, then you say it is passed, or if the difference is less than 3 between the right hand and the foot. Now, if this does not happen, that means it is between 90 to 94%, or the difference is slightly more, rescreen it. But let me tell you, pulse oximetry is a very, very important way, not only to pick up congenital heart disease, some of the lung disease also. Next, please. Next. So this is a good example. So just to reiterate, is the baby cyanotic? Is the baby in shock? Because any newborn with congenital heart disease will only approach in 3 to 4 ways. Either there will be a central cyanosis, which is increasing, or the baby will come in a shock, or the baby will come in heart failure, but it is a late feature. So usually cyanosis and shock. So you have a normal child, suddenly you find the child is in shock. Heart failure comes later. Sometimes murmurs, but murmurs can be normally also seen. But the SpO2 screen failed. That means the pulse oximetry has failed. So heart failure will show you tachypnea, tachycardia, tender hepatomegaly. If it is in shock, the CRT will be prolonged. There will be difference between the core temperature and the peripheral temperature, and the femoral pulses will be. So this also is seen in left ventricular outlet obstructions. Okay, next please. And when you are feeling the pulses, so you have auscultated, we have said about dextrocardia. Next please. Now the metabolic. So we have done with visible, we have done with functional, now with the metabolic. Now what you are going to do, you are going to take a drop of blood. Now usually people say in India, which is the commonest metabolic defect. Now if I put metabolic defect as something where you want to take a drop of blood on a Guthrie's card, then I would say you should think about G6PD and hemoglobinopathies as far more common than congenital hypo. But this does not mean that you should not screen. So you should screen for congenital hypothyroidism and congenital adrenal hyperplasia. So in priority would be hemoglobinopathies, G6PD, then congenital hypothyroidism, because congenital hypothyroidism is roughly 1 in 1,000 and hemoglobinopathies could be far more common. Next, please. So in newborn screening, if you have less money, and if the baby is asymptomatic, then you do universal screening, which is congenital hypothyroidism, sickle cell disease, CH, and G6PD. If the baby is sick, then instead of just seeing the blood for TMS or GCMS, examine the child clinically, do some bedside test like a blood gas. It will give you an anion gap. It will give you some understanding whether it's metabolic acidosis or alkalosis. Do a fasting blood sugar, do a ketones, do a ammonia, do a lactate, do a liver function test, creatinine, a blood cell count, a uric acid, and a serum calcium. And we are forgetting how to do bedside, reducing sugar, ketones, ferric chloride, DNPH, cyanide nitroprusside, MPS. People say, why do this? Because when you send it for tender mass spectrometry and GCMS, the report takes time and it is costly. And we should not forget how to do the bedside test. Next, please. And please remember to take the family history. So this is how you could take the card. I think you have an excellent place in Delhi. Professor Seema Kapoor and AIMS Delhi, Madam Kabra, they are the people who are doing. And let's not forget also our great professor, Professor I.C. Verma, who gave the entire life to this. And this was also developed in Gangaram Hospital. So in Calcutta, I was using this for newborn screening, a very simple method doing isoelectrofocusing. Next, please. So this is how with the isoelectrofocusing, you could pick up a lot of them. It was very cost effective. We could do the babies, we could do all the, but somehow this machine is no longer available in the same way it was available earlier. Next, please. And so at our AIMS, next quickly, next. So this is how we examine it. Next, please. So you do the visible birth. Next, please. The universal hearing screening. Next. Yeah, we have developed an instrument by which you attach your smartphone to the ophthalmoscope, and this can be done within 15 seconds. This our nurses do it, and these are the actual pictures, so you can see the red reflex. Okay, so if you don't see red, you need to. Next, please. We are also doing a fundoscopic examination. In all, this is how we generate from Welsh eye ophthalmoscope. We have attached it with the software. Next, please. So for all babies which are born, we also do the intraocular pressures, again by a keeler pulsometer, which is a no-touch technique. Next, please. And this is all being done by technicians. Then we do fundoscopy for all the babies. And not only for ROP screening, you detect other congenital abnormalities, some of the IEM cases, some of the intrauterine infection cases. So you could pick up, let's say, chorioretinitis by doing a fundoscopy, or a coloboma of the retina, which looks very normal eye by doing retinoscopy. Next, please. Fundoscopy, sorry. So you can see it. This is how. So you can see hemorrhages. You can see a lack of pigmentation, excessive pigmentation, or you can see the blood vessels, which you can see. Next, please. So we have picked up hemorrhages. We have picked up coloboma. This is the BERA and the OA screening reports, which we see. Next, please. We can run it faster. Next, please. Yeah. We have tried to develop something very innovative. Just one back. The ECG. So we are doing newborn screening. Can you go back once? The ECG screening. So this instrument, we have designed it, and we did experiments how to reduce the pressure, how to do the ECG in every newborn without making the child cry. So we put a camera, and this is in progression, how the waves and a lot of arrhythmias have been picked up, which would have been missed. So this is the exact picture. And this next, please. So the next slide is the forma for screening the pulse oximetry. This we have already gone. Next, please. Next. Yeah, this is the neurological examination, which can also be done. So the red ones are the abnormals. So before discharge, you should quickly do it. And this even a nurse can learn. Next, please. This is a modification of Hammersmith. Then the metabolic screening, which we do thyroid screening from the cord sample. Optional. We don't have TMS at our place, so we have to send it out. Next, please. This is if you are doing an inborn metabolism child which is symptomatic, do a blood gas, and you should be able to do. This is a flow sheet diagram. Do the lactate, do the ketones, do the urinary ketones. So this is just to, you all know this, but just to reiterate how important it is to do the bedsides. Next, please. But what we in test, next please. Yeah, this is something which I would ask you that you can procure. It's not very costly. Bedside blood ammonia test. This we are doing it for our babies. Bedside lactate analyzer, bedside blood sugar and ketones, and also trying to develop bedside cyanide nitroprusside tests, ferric chloride test, urine ketones, DNPH, yellow precipitate, so ketostic. So some of the things you can do at the bedside, even if you don't have a very costly equipment called tender mass spectrometry or for urinary GCMS. Next, please. So this is the newborn screening of the following disorders. Next, please. Now, before I end, I have just 2 more slides. In Kerala, mass screening was done. And they were doing it in this format. And I, being an advisor to them, we said, let's do it in visible. And this was being done by nurses, functional, metabolic, and neurodevelopment. Next, please. Now we have the 5th, which is structural also. Next, please. And then they would refer it. The ones which are red would require urgent referral. The ones with yellow, semi-urgent. And with the blue, they could be still less urgent. Next, please. So each of these cases were tracked. Now, what happened because of this? This is an important statement and a closing slide. If you do the newborn screening properly, I'm going to tell you a very historical fact. Remember the year 1963, the president of USA, Mr. Kennedy, had his son Patrick Kennedy with a weight of 2112, lost his life for something which was treatable. It was premature. Now, 1963, what was the IMR of USA? Well, it was 25. What was the IMR of Kerala? It was 120. From 2004 to 2017, the IMR of Kerala was hovering between 10, 12, 13. All these years from 4 to 17, no changes. Whereas the IMR of USA was between 6.9 to 5.84. In 2018, I was called. I could convince their health minister, and this program was launched. In the next few years, it dropped down to 7.665, and you should all appreciate that in 2023, the IMR of Kerala is 5, whereas the IMR of USA is 5.48. Ladies and gentlemen, this is what a proper screening and follow-up can do in terms of IMR. Next, please. So I end up with the slide from Gitanjali Tagore. We have not yet understood the newborn. So Tagore asks, the sleep that flirts on the baby's eyes, does anyone know from where it comes? And he thinks, pauses, and then says, that smile that flickers on the baby's lips when he sleeps, does anyone know from where it was born? So all of you have seen babies smiling when they sleep. Does it mean something if they don't, or does it mean a lot? Thank you very much. And sorry for the glitch which happened. I should have completed it much earlier. Thank you.
Thank you.
Thank you, Dr. Arun, for a wonderful presentation.
Questions ले लो अजय, question answers में.
So someone has said how to differentiate between macrocephaly and megacephaly. So I think that you should start by clinically examining. Do you think that the skull, because what can relate to a large head? Cephaly means a head in Latin terms. So we do not know this large head. Is it because of the brain itself, the encephalon being large? Or is it because there is a fluid that is a hydrocephalus or hydrancephaly? Or is it large because the skull is thick in cases of achondroplasia? Or there is some subdural collection? So I think if you know the order, then you should clinically examine, seeing the skull, doing your transillumination test, hearing for any bruit. And once you have ruled out that the skull is not thin, there's no subdural fluid, you can do X-rays and then ultrasounds also. This will help you. But once you have ruled out, then we are dealing with the megaencephaly. Then the next...
So Dr. Ranjan has asked when to screen for the hemoglobinopathies.
Yeah. So this is a very, very important question. And I had a lot of debate. So I would say for sickle cell anemia, you can examine it in newborn period itself. For thalassemia, people question that since the hemoglobin A2 has not yet come, how do you screen for thalassemia carriers? So what I have always said, that if you do a ratio of HbF versus hemoglobin adult, and you have made out the cutout, whether in the fetus or gestational wise, yeah, so you should do it at birth only. Yes. Please,
Pankaj, please go ahead.
Will it be, Dr.
It can be done at birth. At birth, you screen for sickle cell. This is universal screening. It is being done in United Kingdom for Asian children. But if you are using a proper instrument where you can quantify the hemoglobin A and F, this ratio can also help you to screen for thalassemia and carriers.
So, Dr. Arun, will you recommend sickle cell disease prevention or this screening for all Indian children, or you will specify for certain particular reasons? Or
yeah, a very good question. Very good question. So initially the ministry thought that only for tribal children will screen for sickle cell. But what is coming out, the research done by Bombay ICMR, that now we have a population which is mixed. So if you go to Bengal and Assam, it could be hemoglobin E along with beta thalassemia, okay, which is presenting as a major. So this pure divide between sickle cell and remember, we are using the same instrument. You are not using two different instruments. So if you are using HPLC, you could pick up sickle cell, you could pick up other hemoglobinopathies, you could pick up. So I would recommend that let us do a proper screening of the newborn and definitely sickle cell. And the population which you are getting is mixed. The mother is sickle cell carrier, father is thalassemia carrier. So, we are now getting the marriages are happening, etc. There's no longer a pure population excepting in Andaman Nicobar. So this I would say. Yes.
Dr. Joshi wants to make a comment. Dr. Joshi, you want to say?
Actually, about the sickle cell disease, my demography is one of the area of the country which is with the highest prevalence of sickle cell gene. And our government has launched a pilot project in almost 3 to 4 districts of neonatal screening for sickle cell disease. I think the when you talk about a comprehensive neonatal screening, one of the variable which will decide the priorities will be the demographic location. If at all, sir agrees with me.
I fully agree with you.
Yeah,
I fully agree that we should.
And if at all I am living in the northern part of the country, then G6PD would be very high on my list. If at all, so, and of course the hearing has to be offered to each and every newborn. Who I think sir has already spoken about that. So that is a big takeaway. A simple pulse oximetry of 4 limbs at the time of discharge can always diagnose, can always raise a doubt for a critical congenital heart disease. So, sir, very, very comprehensive and lucid. And the most important takeaway is neonatal screening is just not using the expensive gadgets and the blood test, but it is the basic clinical examination head to toe with a good systemic examination and a very comprehensive family history. Thank you, sir. Thank you so much.
Some of the questions I'll quickly take it. I can see on it. So someone has asked what is the latest definition of low set years. So please refer to the latest Nelson. You will get it. It is joining the two canthus, and if it passes the outer canthus in one line, and if it passes above the ear, that's how the loset is. But let's not go into it, into this. These are all academic discussions. They do not lead much to it. You have said, what is the inference we draw from extended legs and flexed upper limb? So again, let me tell you, normally, physiologically, first, all the 4 legs are extended in a fetus. Then slowly the legs flex, then the trunk flex, then the arms flex. Now, if you see a reversal of this, that the arms are already flexed and legs are extended, then it means there is a brain damage.
Newborn examination is very difficult. I'm sure you are settling at your institute, but what is your advice for others?
So I think that what I have done, now let me tell you, most of the newborn screening, both in Kerala as well as in my place, is done by nursing staff. So you have to give them a pictorial, and I can share you a very simple pictorial drawing by which you can teach a nurse. I don't think a doctor in this entire country has so much to do that he can spend a lot of time on screening. So I think screening should be also taught to nurses, and where there are no nurses, even to anyone who is available with some training can be taught. At least at our place, nurses are picking up. I think it is just a matter of habit and someone to monitor it. I don't think it is that difficult, but my only message, and I'm so happy that IIP has reiterated it, that our students think newborn screening means only newborn blood screening. So they send it for genetic examination, they send it for GCMS and tendermas. By the time the report comes, the patient is already discharged. Now, that's not a very great idea. Doctors are the leaders. You have to develop your own system.
So why pulse
newborn eye examination? Yeah, that is better. And eye examination. Now, let me tell you, there was once a time, even my DM students, they were not doing newborn eye examination. I think it is more a practice rather than. I will tell you, and the other day I was sharing it with the professors of PGI Chandigarh, that a nurse is picking up less than 10 seconds. If anyone want, even the IIP want, give me a class 8 pass girl, I can document a proper red reflex and teach it. You require one instrument and it requires some software. We have developed it. We can share it with everyone. So you don't have to depend on your residents that they have properly seen the red reflex or not. And I would say fundoscopy also, you don't require any doctor. My fundoscopy is done by nurse Shiny Peter, and there's another male nurse, Pankaj. So both of them are doing a great job. So it is possible. It is possible.
How to thyroid profile?
We do an MRI spine in. Yeah. So I think we will leave this to it, and some of the questions can be answered. I think I've already crossed my limits. Dr. Pankaj, if you want, we can extend it. Whatever is you are the leader. Whatever you say.
No, I think it's 10:35. So thyroid profile will answer, because that will be a long answer to give. How to interpret, because it will depend on whether you're doing TSH or T4. What is the time limit within 10 days or beyond 10 days? So that will require a little more detailed discussion.
Yeah. It will be a different discussion altogether. So today we were just walking. Yeah, please. Any
app or website for systematic schema of whole examination? I think the RBSK,
I would say there is. Yeah. RBSK developed it, but it didn't go to the final stage. I think Dr. Seema Kapoor, she has named it Neve. She has also tried to develop. I think, and I would congratulate you to Dr. Pankaj, if you can take the leadership. Everything is ready, a proper app to be developed and used free of cost. It will be a huge data, and it can be put on a cloud, which IIP Delhi can see it. I mean, you are sitting in the capital. If you can do it, it's a huge data which will tell you area-wise why a birth defect is more common in one area and less common in one area. What is the way lifestyle issues? What is the climatic conditions? What are the foods they eat? Why suddenly a birth defect has increased in a particular area? All this can be is a new factory coming up there. Let's say in Gurgaon, some new factory has come up. Then you can think about, well, this is related. That's how the Minmata Bay disease was picked up by a pediatrician.
So we don't have to dilate eyes for eye reflux, that is for sure.
No, not at all. Not at all. Not at all.
G6PD
I
can
will
be
not.
tested anytime. G6PD
Yes,
can
yes.
be tested in cord blood and later
Yeah,
on, no problem.
Yeah. So there are methods by which you can do low cost also.
So if there is MRI spine required for sacral dimple at birth,
I think that is a very tall order. We should first of all clinically examine the baby, record your finding, and follow up the child. If it is feasible to do MRI, like we sitting there, patient doesn't have to pay, you can afford to do it. But usually MRI doing is not only time taking, it is also costly. So I would say, do it first, clinically examine it, do the functionality, follow up the child. You see, some areas you don't have to respond immediately. So the whole newborn examination should be divided into 3 parts, where I need to treat within 24 to 48 hours, where I need to treat in 1 week, where I can follow up the child.
Dr. Rakesh Bhatia is asking a very pertinent question, which has already been answered by RSBSK program, and we also have a standard format for filling up by general pediatricians, everybody for major congenital defect, but it is still not very well circulated. That is why a common pediatrician may not be knowing it, but for everybody's benefit, I will share that into the group and you can always fill it up because it is already there for quite some time. Yeah. Yours, sir.
And Dr. Pankaj, you can further improve on it. This was developed by me, so there is no copyright issue. Let IIP Delhi take it. You can take the leadership, you can further improve it. This was done about 5 years back. There are new knowledge, and all of you who are experienced so much in doing, especially from your center, from Dr. Seema Kapoor's, from AIMS Delhi, all those centers which have a directory, they can all pick up and you can rechange it. So from my side, that could be used as a basic format, and then you can modify it according to your needs.
So that comes to the end of this session. I think it has been an excellent session lasting 1 hour and 40 minutes. And it is great that we start with maximum registration touched around 300. Still there 187 people are on the platform, which speaks volumes about the efficacy of this program and also the versatility of our speaker, Dr. Arun Singh, who has been able to capture all audience for such a long period of time on a Sunday morning. So with this, thank you so much, and over to Dr. Alok for final words.
Yeah. It's been really great. Thank you, Dr. Arun and Dr. Joshi, for taking out time and spending so much and keeping our audience spellbound. It's been a very fruitful Sunday morning. I think let's close the session.
Please join in time next time also. And Mr. Sushil, please